Welcome to section 3 of renal pathology. In this section, we'll be discussing nephrotic syndrome. Let's get started. In this lecture, we'll be discussing the definition, pathophysiology, clinical findings, and causes of nephrotic syndrome. Let's start with the definition. Nephrotic syndrome is defined as glomerular disorders identified by proteinuria. For the disorders to be classified as a nephrotic syndrome, the patient must present with greater than 3.5 grams of protein in his or her urine over the course of 24 hours, or a day. And this is an important number to remember. Proteinuria can present as frothy urine and may be represented in test questions as 2+ or 3+ protein in urine. This just indicates that there's protein in the urine, and it's not quantitative or correlate to even the specific value of greater than 3.5 grams per day. So the quantitative measure is greater than 3.5 grams per day. Here's an image of a glomerulus. Remember from physiology that the glomerulus filters blood that arrives at the kidneys. It is made up of several components, including small capillaries, labeled here as the afferent arteriole and efferent arteriole. It also has a basement membrane, which you can see with that dark blue line. And there's podocytes, which are these green cells. And the basement membrane and the podocytes prevent large molecules, like proteins, from passing through. In glomerular disorders, one or all of these structures are damaged. And glomerular disorders with damage to podocytes impairs its ability to block protein from entering the urine. And that leads to nephrotic syndrome. Next, let's discuss the pathophysiology of nephrotic syndrome. Different types of glomerular disorders can cause glomerular injury, which then leads to podocyte disruption. This causes impairment of the charge barrier, which leads to inappropriate filtration. In other words, molecules that are not supposed to enter the filtrate, like large proteins, are actually able to cross the barrier and be excreted in the urine. In other words, when thinking about nephrotic syndrome specifically, be thinking about podocyte disruption. Next, let's discuss the clinical findings in nephrotic syndrome. Due to damage to the glomeruli natural barriers, proteins like albumin, gamma globulin, and antithrombin 3 are lost in the urine. So, serum levels of these things will go down. For example, there will be hypoalbuminemia, and this will lead to pitting edema. Let's make sense of why edema occurs. First, it's important to know that serum albumin has significant oncotic power, so it helps maintain oncotic pressure in the plasma. If albumin is lost in the urine, then the plasma loses that oncotic power. So fluid will leave the vessels and shift into the interstitial space, resulting in edema. Now let's talk about another protein. When the patient has low gamma globulins, they have hypogammaglobulinemia, which means low antibodies. And if you have a low antibody count, that will naturally lead to an increased risk of infection. With loss of antithrombin 3 in the filtrate, then this can cause certain problems as well. It's important to know that antithrombin 3 is a protease that prevents abnormal blood clots from forming. Hence, it's antithrombin. So it would make sense that loss of antithrombin 3 would result in a hypercoagulable state. In fact, a notable complication of nephrotic syndrome is renal vein thrombosis. And now it makes sense why. The patient lost antithrombin 3. So they're clotting more. Renal vein thrombosis presents with a sudden onset abdominal or flank pain and left-sided varicocele and elevated lactate dehydrogenase. Finally, the low oncotic pressure that occurred as a result of hypoalbuminemia will also trigger lipoprotein production in the liver, leading to hyperlipidemia. Impaired lipid metabolism due to decreased lipoprotein lipase also contributes to hyperlipidemia. So, in response to the nephrotic syndrome, picture the liver trying to produce more lipids. And overall, the patients will have hyperlipidemia and hypercholesterolemia, and that presents as fatty casts in the urine. So we've covered the definition, pathophys, and clinical findings of nephrotic syndrome. So now let's talk about the causes. The primary causes of nephrotic syndrome are minimal change disease, focal segmental glomerulosclerosis, membranous nephropathy, diabetic glomerulonephropathy, and systemic amyloidosis. We'll be discussing each of these in detail using a table. As we mentioned earlier, nephrotic syndrome is characterized by podocyte damage and proteinuria. And what's the quantitative measurement of proteinuria that qualifies as nephrotic syndrome? In other words, how many grams per day? Greater than 3.5. Over on the right, we see nephritic syndrome. This is characterized by glomerular inflammation and bleeding meaning hematuria. Nephritic syndromes are discussed in the next lecture. So here's our table listing the nephrotic syndromes. Let's start with minimal change disease. Minimal change disease is the most common cause of nephrotic syndrome in children, and it's usually idiopathic, but it may be triggered by a recent infection, as well as NSAIDs, immunization, or some sort of immune stimulus, anything that stimulates the immune system. These events all have in common the release of cytokines, which then damage podocytes. Minimal change disease is also associated with Hodgkin lymphoma. That's because Reed-Sternberg cells in Hodgkin lymphoma release cytokines. And why are cytokines important? Because they damage the podocytes and cause nephrotic syndrome. A biopsy from a patient with minimal change disease will look normal on an H&E stain, but on electron microscopy, it will show effacement of the podocyte foot processes. Regarding biopsy findings, this podocyte issue seen on electron microscopy is the only abnormality you can see, because even the immunofluorescent stains will be negative. So H&E normal, immunofluorescence is negative or normal, so effacement of foot processes is all you see. And again, that's just on electron microscopy. And it makes sense why this is called minimal change disease, because there are minimal changes that you can see. Of note, minimal change disease has a great response to steroids like glucocorticoids. And steroids inhibit the production and action of most of these cytokines. For more information on glucocorticoids, our image mnemonic in our immunology pharmacology chapter is super helpful. Let's try a question. An 8-year-old boy is brought to the office due to swelling of the hands and feet. 2 weeks ago, the patient was treated for anaphylaxis following a bee sting. He mentions that his pants feel tighter than usual. The patient's urine has also become frothy. Physical examination reveals lungs that are clear to auscultation. What other condition is most likely associated with the patient's disorder? Okay, so this patient presents with edema because he has swelling of the hands and feet, and also his pants feel tighter. And all of this following a bee sting. And he also has proteinuria because of that frothy urine. So we're thinking of nephrotic syndrome, and that represents this frothy urine represents greater than 3.5 grams of protein in the urine per day. You can't make that assumption just clinically, you need to measure it, but we're going to assume that this patient has nephrotic syndrome. And if he does, which one are we thinking about? Well, his most likely diagnosis is minimal change disease. And we think that because that's the most common cause of nephrotic disease in children and often presents following an immune stimulus, like anaphylaxis in this case. But what we're asked specifically is what other condition is most likely associated with this patient's disorder. So the patient's disorder is minimal change disease. What condition should we be thinking about? Hodgkin lymphoma. Okay, so that answers our question. And as just a brief review, what serum protein is likely low that results in the swelling or edema of this child's hands and feet? That would be albumin. He has low albumin. Let's move on to focal segmental glomerulosclerosis. This is the most common cause of nephrotic syndrome in Hispanics and African Americans. And this disorder is usually idiopathic. However, it may present secondary to HIV, heroin use, and sickle cell disease. Now, following a biopsy, H&E stain presents with focal and segmental sclerosis. Focal means that not all glomeruli are affected. Segmental means that only certain segments of the glomeruli are affected. We'll look at an example of this in a bit. Now, like minimal change disease, on electron microscopy, focal segmental glomerulosclerosis presents with effacement of the podocyte foot processes. And on immunofluorescence, the parts or segments of the glomeruli that are affected may be positive for non-specific focal deposits of IgM, C3, and C1. Here's an H&E stain of focal segmental glomerulosclerosis. Segments show sclerosis. Sclerosis is the replacement of normal tissue with connective tissue. So it would appear as excessive connective tissue where it's not ordinarily found. And this image only shows one glomerulus, but in a full view image, you would see some normal glomeruli with some segmentally sclerotic glomeruli, like the one we're seeing here. Okay, let's move on to membranous nephropathy. Membranous nephropathy is usually idiopathic, but it may result from antibodies to the antiphospholipase A2 receptor. Before moving on to the associated conditions, I just want to point out that the three conditions we've discussed so far are all usually idiopathic: membranous nephropathy, focal segmental glomerulosclerosis, and minimal change disease. So that's usually how they present. But it's important to know those other details, such as antibodies to phospholipase A2 receptors in this membranous nephropathy case. Now, membranous nephropathy can result secondary to hepatitis B or C infections, as well as syphilis infections. It can also occur from solid tumors and systemic lupus erythematosus, or lupus. And it can also occur secondary to drugs like NSAIDs, gold, and penicillamine. So just a reaction to these substances. Membranous nephropathy has several abnormal biopsy findings. On H&E, it presents with a thick glomerular basement membrane. Electron epithelial deposits with a characteristic spike and dome appearance. And immunofluorescence of membranous nephropathy has a granular pattern as a result of IgG and C3 deposits in the basement membrane. Remember from immunology that C3 is a complement protein, and it's elevated in response to an inflammatory reaction which may be seen in membranous nephropathy due to antibody binding the glomerular basement membrane. So here's an H&E stain of membranous nephropathy. Notice this basement membrane here appears thickened. You can follow it around. You can just see that it's diffusely thickened. And what deposits here causing this appearance? IgG and C3. Here's a zoomed in image of membranous nephropathy with a silver stain. Silver stain will stain the DNA, or proteins and other cellular components. In membranous nephropathy, the IgG and C3 deposits are stained, and so you can more clearly see that they're subepithelial deposits. Some call these findings that spike and dome appearance, and in this one it's a little bit easier to see the dome idea. Let's try another question. A 42-year-old man with a history of Wilson's disease comes to the office for evaluation of progressive generalized edema and weight gain for the past several weeks. Mild ascites is present. There is bilateral lower extremity pitting edema to the knees. Urinary protein excretion is 6.0 grams over 24 hours. A kidney biopsy is ordered. What is the most likely finding on electron microscopy? Okay, so this man presents with progressive generalized edema and weight gain and proteinuria. And how many grams of protein in the urine is required to qualify this as nephrotic syndrome? Greater than 3.5. And 6 grams over 24 hours definitely qualifies as that. And with these signs, we can determine that he has nephrotic syndrome. And now we have to figure out the cause of his nephrotic syndrome. Well, we're told that he has a history of Wilson's disease. And to get this question right, you need to know how Wilson's disease is normally treated. So you may need a refresher on Wilson's disease. What drug treats Wilson's disease? Well, part of Wilson's disease treatment is penicillamine. Again, getting this question correct might be super hard if you're not very fresh on Wilson's disease. But now that you know that Wilson's disease is treated with penicillamine, can you connect that to the correct type of nephrotic syndrome? Penicillamine is a secondary cause of membranous nephropathy. Membranous nephropathy presents with subepithelial deposits with a spike and dome appearance. So the electron microscopy finding that we're expecting is subepithelial deposits. And that answers the question. We've covered minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Let's move on to diabetic glomerulonephropathy. Diabetic glomerulonephropathy occurs because of diabetes mellitus, and diabetes mellitus presents with hyperglycemia, which leads to non-enzymatic glycosylation of the vascular basement membrane. Non-enzymatic glycosylation is, as the name suggests, the adding of a glucose group to the vascular basement membrane without the use of an enzyme. And since this reaction is not catalyzed by an enzyme, it's not well regulated, which allows the accumulation of glucose at the basement membrane of the vascular wall. This causes hyaline arteriosclerosis, and we're thinking of the afferent and efferent arterioles of the kidney. Those are the ones that are experiencing this hyaline arteriosclerosis. And the glomerular efferent arteriole is more affected than the afferent arteriole. And this leads to high GFR. High GFR leads to a hyperfiltration injury, which causes microalbuminuria. In this state, the kidneys are losing small amounts of albumin. As the kidneys begin to lose larger and larger amounts of albumin, it eventually progresses to nephrotic syndrome. And the associated condition of diabetic glomerulonephropathy is, obviously, diabetes. The biopsy of diabetic glomerulonephropathy is characterized by sclerosis of the mesangium and formation of Kimmel-Still-Wilson nodules. Here you can see the mesangial cells, these blue cells next to the juxtaglomerular apparatus. And this mesangium is a space which is continuous with the smooth muscles of the arterioles. And again, the arterioles right here, you can see endothelial cells, the afferent arteriole and the efferent arteriole. And this mesangium is surrounded by capillaries, as you can see here, but it's clearly outside the capillary lumen. But this whole area, including the arterioles, becomes sclerotic in diabetic glomerulonephropathy, hence the term hyaline arteriosclerosis. Here's a micrograph of diabetic glomerulonephropathy that shows the Kimmel-Still-Wilson nodules. The mesangium here is also sclerotic, so this means that there's connective tissue in the mesangium. But again, these Kimmel-Still-Wilson nodules are pathognomonic for diabetic glomerulonephropathy. So let's try another question. A 67-year-old woman comes to the physician with a 5-month history of fatigue, recurrent urinary tract infections, and dysuria. Physical examination shows 2+ pitting edema of the lower legs and ankles. Kidney biopsy shows Kimmel-Still-Wilson nodules. What is the initial cause of this patient's renal findings? So hopefully you recognize that this patient has a nephrotic syndrome. And we're told what type because of these nodules. So the patient has diabetic glomerulonephropathy. So the patient obviously has diabetes. But the question is getting at what is the initial cause of the renal findings? So this just means think about the underlying pathophysiology that leads to this nephropathy. And this is an open-ended question, so there are multiple right answers potentially. But the idea is to remember that it starts with non-enzymatic glycosylation of the vascular basement membrane. Or even before that, there's hyperglycemia. And that leads to the glycosylation, which eventually leads to hyaline arteriosclerosis and causes diabetic glomerulonephropathy. So that answers our question. Okay, let's move on to systemic amyloidosis. Systemic amyloidosis causes nephrotic syndrome by depositing amyloid in the mesangium, and that damages the glomerulus. So notice that there's nothing here written in associated conditions, and that's because amyloid can be high in anything that causes inflammation. So there's virtually an endless list of things that can cause this. What you need to be able to do is recognize that amyloidosis can cause apple green birefringence under polarized light using a Congo red stain. And of course, you'll see amyloid deposits in the mesangium. Here's a light micrograph of systemic amyloidosis with amyloid deposits in the mesangium. You can see that thickening there. This fuchsia pink area is the area of amyloid deposition, and it's in the mesangium. Again, this is consistent with systemic amyloidosis. Let's wrap up with one multiple choice question. A previously healthy 35-year-old man complains of recent fatigue and swelling of his feet and ankles. He also notes puffy eyes. Physical exam reveals an afebrile man with lower extremity edema extending to the knee, periorbital edema, and a small amount of ascites. Urinalysis reveals 4+ protein and oval fat bodies. 24-hour urine protein is 6 grams. A day later, he develops right flank pain. What is the most likely cause of the patient's most recent symptom? Okay, so this guy clearly has edema and nephrotic proteinuria because it's greater than 3.5 grams per day. So now that we're comfortable he has nephrotic syndrome, we need to think about his most recent symptom, which is his right flank pain. In the context of nephrotic syndrome, what does a sudden onset of right flank pain or even left flank pain suspicious of? That would be renal vein thrombosis. Renal vein thrombosis is a complication of nephrotic syndrome due to the loss of antithrombin 3 in the urine. So the correct answer is A, antithrombin 3 deficiency. Going back to the clinical findings slide, where we discussed the common clinical findings for all nephrotic syndromes, remember that loss of antithrombin 3 leads to hypercoagulability, which leads to renal vein thrombosis. B is incorrect because low oncotic pressure causes edema and hyperlipidemia, which do not directly cause flank pain. C is incorrect because the capillaries are not damaged in nephrotic syndrome. And D is incorrect because bacterial infections do not cause nephrotic syndrome. So again, the correct answer is A, antithrombin 3 deficiency. And that concludes this section on nephrotic syndrome.